Hey everyone! In this video, we're going to learn about esophageal disorders. Now, what do you mean by dysphagia? It's defined as difficulty in swallowing, whereas odynophagia is defined as pain on swallowing. Both dysphagia and odynophagia will cause weight loss if these symptoms persist for a long time. Let's focus more on dysphagia. It's divided into two types, oropharyngeal dysphagia versus esophageal dysphagia. In case of oropharyngeal dysphagia, the difficulty in swelling is localized to the neck region, and the patient often complains of nasal regurgitation, aspiration of food particles, difficulty in initiating the swallowing process as the oropharynx has voluntary muscles which are controlled by our will. Now, what about esophageal dysphagia? It's localized to the lower neck or the epigastric region. The patient will feel like food is getting stuck in the middle of the chest in the epigastrium. The problems are related to peristalsis in the esophagus, which is an involuntary process as it's controlled by smooth muscles. If a person has dysphagia for solids and liquids, the differential diagnosis is usually achalasia, scleroderma, or spasm. However, if a person complains of progressive dysphagia for solids followed by liquids, it can be divided further into two based on age group and weight loss symptoms. Older people, such a symptom usually raises alarm to investigate for neoplasm, whereas in younger people it might be due to rings, webs, and strictures. Remember, a neoplasm is always associated with an older patient with a complaint of weight loss. With this, we come to the first disorder of the esophagus, which is achalasia. Achalasia is caused by degeneration of the myenteric plexus in the lower esophageal sphincter region. The myenteric plexus is responsible for releasing the neurotransmitter VIP, which helps to relax the LES. In the absence of this plexus, the LES won't relax and the LES will remain contracted. The physiological function of this contraction is to prevent the acidic contents of the stomach from going into the esophagus. Now, the etiology for this condition is not known. A small number of people who suffer from Chagas disease caused by Trypanosoma cruzi get achalasia, along with toxic megacolon and dilated cardiomyopathy. Gastric carcinoma or lymphoma can also cause achalasia. What is the clinical presentation of this condition? A patient will complain of progressive dysphagia to both solids and liquids simultaneously. Keep in mind the progressive dysphagia happens simultaneously to both liquid and solid, in contrast to some other conditions where the patient first cannot swallow solids and then slowly cannot swallow liquids either. Patient may complain of regurgitation. There is no relation between achalasia and alcohol or tobacco abuse. That is what differentiates it from esophageal cancer. Now, how do we diagnose it? Diagnosis is done by a barium swallow or barium esophagography, in which you will see a bird's beak appearance at the distal end of the esophagus. The most accurate test, however, is an esophageal manometry, which shows the increased lower esophageal resting pressure, and in the absence of the bird's beak appearance in a barium swallow or barium esophagogram, a barium esophagram. And in this picture, you can see esophageal manometry, and you can see that the pressure at the lower esophageal sphincter is increased. So what is the order of diagnostic evaluation in achalasia? We first start with the barium swallow or barium esophagram, and then we proceed to esophageal manometry to confirm the diagnosis. Upper endoscopy has to be done to rule out pseudoachalasia, which can happen in the case of adenocarcinoma, which affects the same region of the esophagus, especially if a person has alarm symptoms like onset at more than 60 years of age, anemia, heme-positive stools, and more than 6 months of duration, accompanied by weight loss, calls for an upper endoscopy or esophagogastroduodenoscopy. Treatment. How do we treat achalasia? Achalasia is treated by pneumatic dilation. It's effective in 80 to 85% of patients. In this, a catheter is passed through the narrow end of the esophagus, and a balloon is inflated there, which helps open the LES. Botulinum toxin injection is used in some people as a second-line treatment. However, it needs to be repeated every 6 months, which does not make it a very effective treatment modality, and the relapse rate is also very high. It's 50%. Calcium channel blockers and nitrates, which help relax the muscles, which are muscle vasodilators, they are the third line of treatment. They act as muscle relaxants. Surgical myotomy is associated with risk of reflux in 20% patients, and hence it's the last resort.
Okay, so now we come to the next esophageal disorder, that is esophageal cancer. This is a very high yield topic. Esophageal cancer is of two types. You have squamous cell carcinoma, which normally happens in the upper part of the esophagus, the proximal 2/3, and it's associated with alcohol and tobacco abuse. The second type is adenocarcinoma of the esophagus, and it is usually found in the lower part of the esophagus in the distal 1/3, and is associated with chronic gastroesophageal reflux disease, which often leads to Barrett's esophagus. Now, this condition is often confused with achalasia, and hence it's called pseudoachalasia. So, what's the clinical presentation of esophageal cancer? A person has progressive dysphagia, first for solid food and then for liquids. So as the cancer grows, whether it affects the upper or the lower part of the esophagus first, it will be difficult for solid foods to pass through, and then as it increases, even liquids can't pass through. This is characteristic of esophageal cancer. There is prominent weight loss. Sometimes regurgitation and hoarseness may also be present. Hypercalcemia may be present as a paraneoplastic syndrome. How do we diagnose it? First, do a barium swallow. However, endoscopy is most important because we need to take an esophageal biopsy to confirm the diagnosis. CT scan helps determine the degree of local spread. However, endoscopy is the gold standard investigation. Now, treatment. The only effective treatment is surgical resection if the cancer has not metastasized much. However, only 25% of patients are operable when they are diagnosed. And the 5-year survival rate is 5 to 20%. So it's a very aggressive malignancy. The rest undergo a chemotherapy with 5 fluorouracil-based chemotherapeutic agents and radiation to control the metastasis. The next disorder we are going to talk about is scleroderma of the esophagus or progressive systemic sclerosis. What is scleroderma? It's a connective tissue disease which is characterized by deposition of connective tissue in different parts of the body. And so that connective tissue deposition, when it occurs in the esophagus, you get scleroderma in the esophagus. It causes diminished esophageal peristalsis due to atrophy and fibrosis of the esophageal smooth muscles. So there will be esophageal dysmotility. What's the clinical presentation? Although there is dysphagia, the main clue to the diagnosis is the presence of gastroesophageal reflux symptoms in a person with a history of scleroderma. So if somebody comes in with GERD symptoms and he has a history or she has a history of scleroderma, then you have to assume that it's the esophagus affected by scleroderma. The lower esophageal sphincter will neither contract nor relax, and it becomes an immobile open tube because there's no muscle there anymore. The muscles have been destroyed. They have atrophied and been replaced by connective tissue. So there's like a complete lack of peristalsis, and the LES is just open, as you can see in this picture. And that's why stomach acid, gastric acid, can easily move into the esophagus, and so a person has GERD-like symptoms. So how do you treat it? The treatment is with the help of a proton pump inhibitor like omeprazole, or a pro-motility agent like metoclopramide has some effect in this condition. So when you compare achalasia and scleroderma, both of them have decreased peristalsis. However, achalasia will have increased lower esophageal sphincter pressure when you do manometry, but scleroderma will have decreased LES pressure because the LES is just open, there's no muscle there. So that's why motility study is the most accurate study in this condition too. So you have to remember, the most accurate diagnostic test is a motility study. Barium studies are generally unnecessary in scleroderma. Now the next topic is, so this is a picture showing manometry done in scleroderma. You can clearly see here that compared to achalasia, which had a bird's beak appearance. Here you can see that the lower esophageal sphincter, or LES, is wide open. There is low LES pressure. Now we come to the next topic, and severe GERD-like symptoms, esophageal spasm, peristalsis, so and NUTCRACKER esophagus. This is a very interesting condition because sometimes when somebody is suffering from DES, you might think that they are getting an MI. So a young person or an old person will come to you with crushing chest pain for 1 hour with no significant medical history. You will do the ECG, which is normal, and then give sublingual nitroglycerin, which improves chest pain. Now, how do you diagnose this patient? We see that the ECG is normal and there is no medical history. So you assume that this patient has something to do with the esophagus or the GI tract. So we will proceed by doing an esophageal investigation, maybe an esophagram, a barium swallow. But if it was an old person, coronary artery disease is always a risk factor, and so you have to do a stress test first to rule out angina, even if the ECG is normal. Now, esophageal motility disorders are idiopathic disorders and have to do with the neural processes of the esophagus. Diffuse esophageal spasm and nutcracker esophagus are very difficult to distinguish, and the only way we can differentiate between them is with the help of manometric study. The patient will come with intermittent chest pain and dysphagia. The pain can be similar to that of a myocardial infarction, but an important point is that it has no relation to exertion. The pain can occur at rest also, and it does not worsen on exertion. It is not even related to swallowing. It can be there without swallowing too. You don't know when your esophagus is going to get spasmed. So there is no relationship with eating, ruling out adenophagia. The pain can be precipitated by drinking cold liquids. This is important. So how do you diagnose it? The first test that you need to do is barium swallow, which may show a corkscrew pattern, as you can see in this picture, a corkscrew pattern at the time of diagnosis. However, this is not a very specific test. It's not a very sensitive test. It's specific but not sensitive, and it will be normal in a lot of cases. So the most accurate test is again manometric study, which shows high intensity disorganized contractions. So how do we treat it? We treat it by giving agents that will relax the spasm, like calcium channel blockers. And if somebody does not respond to relaxants, then you can proceed to surgery. Sometimes anxiolytics like amitriptyline may also be given. And most of the patients recover through medical management only. Now this is a slide talking about nutcracker esophagus. Nutcracker esophagus is also called jackhammer esophagus or hypercontractile esophagus. And in this, it's even called hypertensive peristalsis because the spasms are really strong. And it's pretty similar to DES, and however the pattern of contractions is different when you do manometric study. Now we come to another type of esophageal disorders called rings and webs. In this, the first disorder we are going to talk about is the SCHATZKI'S ring. It's a small, thin epithelial membrane made out of squamous epithelial cells. It's not progressive in nature, and that's how you can differentiate it from achalasia. Achalasia is slowly increasing. That's why you can't swallow solids and liquids both, but slowly it becomes more difficult to swallow both of them simultaneously. Whereas rings and webs, they are more intermittent in nature. Just like diffuse esophageal spasm, even the rings, the SCHATZKI'S ring leads to intermittent dysphagia, which is not associated with pain. It's more distally located at the squamocolumnar junction and just above the lower esophageal sphincter. So it's not progressive dysphagia compared to neoplasm or achalasia. It's not painful compared to esophagitis, and it's intermittent in nature. And the dysphagia is usually more to solids. Okay? And the SCHATZKI'S ring is associated with something called the steakhouse syndrome, where a person feels that a big piece of food is stuck in the throat, whereas in the esophagus, whereas it's a small piece of food, what they have is a SCHATZKI'S ring. Now, another type of esophageal ring and web is Plummer-Vinson syndrome. This is how a SCHATZKI'S ring looks like in the endoscopic view, which gives you a cross-sectional view. Now, Plummer-Vinson syndrome. Plummer-Vinson syndrome is a very interesting condition. It has esophageal webs which tend to occur in the upper part of the esophagus, in the hypopharynx, and in middle-aged women. However, it's also accompanied by iron deficiency anemia and a glossitis of the tongue. So they will have a beefy red tongue, angular stomatitis, an esophageal web, and iron deficiency anemia, which can lead to dysphagia, and it's also associated with squamous cell carcinoma. How do you treat it? You treat it just like you treat achalasia, with the help of balloon dilatation. And iron may be necessary for Plummer-Vinson syndrome. Next, we come to another type of esophageal condition called esophagitis. Now, most common esophagitis is due to candida infection and is very common in people who are HIV positive with a CD4 count less than 200 millimeters. It can also be due to herpes simplex, cytomegalovirus, and aphthous ulcers. Pill esophagitis is also very common, which can happen because of many drugs like bisphosphonates, alendronate, quinine, risdronate, vitamin C, potassium chloride, doxycycline, NSAIDs, and iron sulfate. Okay? So the barium swallow is incorrect step for esophagitis. Remember that. It's not the correct first step. So if a person comes with candida esophagitis and progressive odinophagia, what do we do? You need to know that the pain is only on swallowing, while in spasm, DES, or nutcracker esophagus, the pain is intermittent and is even present without swallowing. The pain in esophagitis is because the food is rubbing, there's friction with the inflamed esophagus. So in case of candida esophagitis, the treatment is oral fluconazole. And oral fluconazole is not only therapy, but it's also diagnostic. If symptoms improve, then you know that they had Candida esophagitis. Just give them oral fluconazole even for diagnosing this condition. If symptoms don't improve, then you have to do endoscopy and biopsy to exclude other conditions like herpes simplex virus and cytomegalovirus. And if the option is nystatin, rinse and swallow, then remember it will not work because it's only effective in oral candidiasis, which sometimes happens in people who take inhaled steroids. But esophagitis cannot be cured by nystatin. You have to give fluconazole. Now, in case of pill esophagitis, you have to make sure that when somebody is taking this kind of medication, like a young person taking acne medication or an old woman with osteoporosis taking bisphosphonate, you have to make sure that they take have proper pill hygiene to prevent the development of esophagitis. You have to sit up straight and take the pill with a lot of water, and even after you take the pill you have to stay upright for half an hour. Okay, but if they already have pill esophagitis, there's no other way out other than stopping the medication which is causing it. Next we come to eosinophilic esophagitis. Eosinophilic esophagitis happens in people with a long history of allergies like asthma or eczema. And somebody with this kind of history will suddenly have difficulty in swallowing. And if you do a trial of proton pump inhibitors, even after that the condition will not improve. Why? Because it's not because of acids, it's because of eosinophils. However, even GERD can cause eosinophilia in the esophagus, and it's often confused with eosinophilic esophagitis, and so you need to rule out GERD. That's why you give an 8-week trial of PPI. If it improves, you know it was GERD causing the esophagitis. If it does not improve, then you know that it's eosinophilic esophagitis due to allergy. The treatment for this is swallowed steroid, swallowed budesonide or fluticasone. If the biopsy shows esophagitis with eosinophils, you have to know that you always start PPI before steroids, because steroids have other harmful effects associated with them. So you always want to give proton pump inhibitors first to rule out GERD. Now we come to ZENKER's diverticulum, which is a pretty high yield topic. Now, what's a diverticulum? It's an outpouching. So a ZENKER's diverticulum is an outpouching in the posterior pharyngeal constrictor muscles at the back of the pharynx. And what's the clinical presentation of this condition? The person will gradually develop the ZENKER's diverticulum, and it's pretty common in older patients. And not seen that frequently in younger people. So they will have halitosis or bad breath. Difficulty in initiating swallowing is there because the lesion is very proximal, so it interferes with the voluntary muscles there. They need to repeatedly clear their throat. Sometimes there's undigested, regurgitated food from like several days ago, so it's pretty yucky because the food gets lodged in the diverticulum and is regurgitated. The diagnosis is confirmed by a barium swallow. As you can see here, a ZENKER's diverticulum is seen in this barium swallow. It's the first and the best test to do. You don't need to do any test after this. No endoscopy or nasogastric intubation allowed because it can perforate the ZENKER's diverticulum, leading to perforated pharynx. Okay, the treatment is surgical resection. Now, the last section on esophageal disorders is on esophageal tears and perforation. First, let's talk about a tear which does not go all the way across, so it's not a perforation. It's a non-transmural tear of the lower esophagus, and it's related to repeated retching and vomiting. So somebody who has done binge drinking, pregnant women with hyperemesis gravidarum, all these people can have Mallory-Weiss tears. So there's no dysphagia, no odynophagia, there's just a painless upper GI bleed. Sometimes there's black stool if the volume of bleed is very, comparatively higher, more than 100 milliliters. And it's increased in patients with hiatal hernia. Hematemesis is seen in 85% of patients. You have to do an upper endoscopy to visualize a Mallory-Weiss tear. Mostly they resolve on their own. Sometimes when they don't, it may be necessary to inject the tear with epinephrine to cause vasoconstriction, or you may need to cauterize those tears. This is how a Mallory-Weiss tear looks endoscopically. You can see it's not all the way through, it's just a superficial tear. What happens in esophageal perforation? Okay, now this is a picture of the normal CT scan of the esophagus. You can see the aorta here. This is the trachea, the big circle. The small circle with a comparatively thicker wall but still not that thick is esophagus. Right lung, left lung, and spinal cord. Now this is a picture with esophageal perforation. You can see that the wall of the esophagus, it's pretty, swollen. So, there's some kind of esophageal pathology there. These are the bronchi and these are the lungs. And here you can see that there is effusion in the lungs. So the esophagus has perforated and then there is fluid in the pleural space. And there's even fluid in the pericardial space. This is a CT scan done in a patient with esophageal cancer. I put this here for you to appreciate how the wall of the esophagus has become thickened in cancer. And even this can lead to perforation of the esophagus. This is another perforated esophagus, and you can see that the effusion, the fluid that has come into the pleural space is a lot. And this is like a very dangerous esophageal perforation. Now, a perforated esophagus can be due to instrumentation, neoplasm, Boerhaave syndrome, or corrosive esophagitis. The symptoms are pleuritic chest pain and sometimes subcutaneous emphysema. When you do a CT scan, you will see air in the upper mediastinum. So it's very important it's a surgical emergency and you need to perform surgery right away to fix this problem. So that's all about esophageal disorders, and I hope you understood the esophagus a little better after this video, and stay tuned for more videos.